Buenos días. Antes que todo, agradecer a la organización de la reunión pues, la oportunidad de poder moderar al Dr. Singh. Y good morning. Hablaré en inglés para la introducción. Good morning, dear colleagues. It's a pleasure for me to introduce Dr. Vikesh Singh. He's a gastroenterologist of Johns Hopkins Hospital in Baltimore and is the director of the Pancreatitis Center and the medical director of the autotransplantation ISLE program. It's true. He's a specialist in inflammatory disorders of the pancreas as well as interventional endoscopy. Please, Dr. Singh.
Thank you very much for the kind introduction, Dr. Fabregat, and I'd also like to thank the organizing committee, in particular Dr. Enrique de Madeira, for the opportunity to come and speak to you about total pancreatectomy. Obviously, I have a fairly big topic here, and I will try to go through this as rapidly as possible. If you have difficulty understanding me because I'm talking too fast, please ask me to slow down, and I'm certainly available to answer any questions that might come up as we move along in the presentation. The area of total pancreatectomy has been garnering more interest not only in the United States but across the world as more and more centers are starting to perform this procedure for patients with intractable abdominal pain due to chronic pancreatitis. This was in fact the subject of an NIH-sponsored workshop last year that took place in Pittsburgh, Pennsylvania, where we attempted to identify some of the problems and some of the challenges that face us as we try to move this field a little bit further along. And the summary of this workshop was published in two sequential papers in Pancreas and the Annals of Surgery, and I encourage you to look at them if you want to see where we're headed in this field. In its simplest form, total pancreatectomy with islet autotransplantation is a relatively simple procedure. The pancreas is removed typically in two parts. Usually the tail is removed and then the head is removed separately, so you're doing a Whipple plus a distal pancreatectomy, and you have very similar post-surgical reconstruction. After removing the pancreas, you actually infuse collagenase into the main pancreatic duct and allow that, and that begins a process of isolating the islets, which after a process of several steps of centrifugation, you actually can re-infuse the islets back through the portal vein where they then begin to effectively engraft into the liver. I think it's important to show you how this works. I hope this video works. Okay, very good. So this is just a quick encapsulation of what happens in this procedure, and I can show you how we do it at Johns Hopkins. The one thing that makes us a little bit different than some of the other centers performing this procedure in the United States is we conduct the isolation and operation in the same operating theater at the same time. Here you can see the surgeons are removing the pancreas, usually in two parts. Here's the head of the pancreas coming out, and I think over here you can see the tail. And what you do is you actually inject collagenase into the main pancreatic duct, and that begins the process of islet breakdown. And then you actually cut up the tissue after infusing the collagenase. And then the specimen is actually is sort of separated a little further using something that we call the belly dancer. As you can see, it's nicely moving up and down. The whole pancreas is in there. Collagenase is in there, and that's where we're beginning to isolate the islets. Here's the surgical reconstruction. Here they're, after the centrifugation cycles, are actually resuspending the islets. It's very important that the sample not be terribly high in volume because that can run the risk of portal vein thrombosis. And now you can see we're hanging up the specimen, and you allow it to gradually infuse directly into the portal vein, which you're going to see right down here. Do you see the catheter is going into the portal vein? Now you have to be careful not only to infuse as little volume as possible, but very, very slowly, because those are in fact the two biggest risk factors for portal vein thrombosis. And now you can see the procedure will wind up. Here's the specimen slowly infusing. The entire operation takes between 6 to 10 hours, depending on, Okay. The entire operation takes about 6 to 10 hours, depending on whether we use an open versus laparoscopic approach. Johns Hopkins has been one of the pioneering centers in laparoscopic total pancreatectomy with islet autotransplantation, and of the 45 cases that we have done in the last 3 years, we have done approximately 1/3 using the laparoscopic approach. So now the question becomes is, who do you select to do this procedure? This is a very challenging area, and I'm going to spend a little bit of time on this. These are the University of Minnesota criteria for total pancreatectomy with islet autotransplantation. This procedure was devised at the University of Minnesota and was first performed in 1977. However, of the approximately 600 cases they have done so far, the majority have been since 2006, because we've found an expanding sort of indication base and more and more patients with chronic pancreatitis who want to be offered other alternatives to treat their intractable chronic abdominal pain. So when you look at the criteria here, there are a few things that I think make a lot of sense. So the first is certainly patients should have chronic abdominal pain lasting more than 6 months. I agree with that. I think that there should be some evidence of recurrent acute pancreatitis, and that's effectively what's shown there in Part B. And I think that anybody who's got a documented history of hereditary pancreatitis, I think that's also another reasonable patient selection criteria. Where I have problems is really with everything in between, because if you remove the calcifications, effectively all the other components of their selection criteria largely involve diagnostic imaging, and we can talk a little bit about the problems with that. One, we know that histology is not really a gold standard for chronic pancreatitis, as there is no consensus among pathologists about the quantity and distribution of fibrosis and chronic inflammation that's needed to diagnose chronic pancreatitis. We know chronic pancreatitis can be a focal and patchy disease. We know that autopsy studies can show atrophy and fibrosis even in the absence of clinical chronic pancreatitis. And we also know that asymptomatic patients who are older, who drink, who smoke, who are obese and may have even concurrent cancer can actually have pancreatic fibrosis. In addition, if we look at all the diagnostic tests that we use to diagnose chronic pancreatitis, all of these studies, which I really call structure and functional tests, have limitations. One is that they have very high sensitivity and specificity for advanced but not mild chronic pancreatitis. In fact, you could argue that we don't even really know what mild chronic pancreatitis is. We don't have a gold standard definition for that. Most studies have evaluated these tests in suspected chronic pancreatitis patients who have very variable risk factors for disease. We know that some are very highly operator dependent, including endoscopic ultrasound. And while these tests are often are often correlated to pancreatic fibrosis, we need to remember that pancreatic fibrosis is not the gold standard, and it doesn't often correlate to pain. One of the best tests that have been performed to actually correlate endoscopic ultrasound, secretin pancreatic function testing, and histology was one conducted at the Cleveland Clinic by Tyler Stevens' group. And as you can see here, as the EUS score rises, so does the amount of fibrosis. And in addition, the 1-hour peak bicarbonate test, which is done as a pancreatic function test, actually starts to decrease as the fibrosis score increases. Now, these are all patients who had surgical resection. However, if you look at the data very carefully in this study, most of these patients had a very high pre-test probability of having chronic pancreatitis. The vast majority are patients who've had acute recurrent pancreatitis, and at least more than 50% of the patients were smokers. So can patients without a history of acute pancreatitis develop chronic pancreatitis? We know that of all the patients who have acute pancreatitis, approximately 20 to 30% of those patients will have acute recurrent pancreatitis. And among the patients who have acute recurrent pancreatitis, about 10% will go on to have chronic pancreatitis. Now, this has been very strongly supported by 2 studies, one conducted by Paul Lankish's group in Germany, where he followed a large cohort of patients for many years. And in fact, I think some patients were followed for as long as 20 years. And as you can see here, the only patients with chronic pancreatitis are those patients who have an alcoholic etiology and who have alcoholic recurrent acute pancreatitis. This was also mirrored by a separate study conducted in the United States by Dr. Dheeraj Yadav, where you can see that the risk of acute pancreatitis was highest in those patients, the risk of recurrent acute pancreatitis was highest amongst those who consumed alcohol, and then the risk of chronic pancreatitis was actually highest in those patients with recurrent acute pancreatitis. So can you develop chronic pancreatitis without having symptomatic acute recurrent pancreatitis? Now, we do know that there is this phenomenon of late onset idiopathic chronic pancreatitis. This was a term that was coined by Peter Layer back in the early 1990s, or at least there were a few studies conducted around that time which sort of reported on these patients. As you can see here, the late onset idiopathic chronic pancreatitis group is generally older. What's interesting is a lot of them have a painless course. So these are patients who might go through their whole life and never actually have pain or acute pancreatitis. However, once they're diagnosed, their median time to developing calcifications, exocrine insufficiency in diabetes is much shorter than those patients who have early onset idiopathic chronic pancreatitis. So I think the important thing to remember if we wanted to answer this question is that yes, patients can have chronic pancreatitis without having symptomatic recurrent acute pancreatitis, but their chronic pancreatitis is not structurally or functionally subtle. Often these patients will present and you'll perform an imaging study, you'll see calcifications, and many may have exocrine insufficiency and concurrent diabetes at the time of diagnosis. So the most fundamental problem that we face really is that we really don't understand pancreatic pain and abdominal pain in general. The current fallacy is that pain drives diagnostic testing and the results of diagnostic testing must explain pain. That is really the paradigm by which we operate. So if a patient presents with upper abdominal pain, we perform a host of studies. So we'll do CAT scan, we'll do MRI, we'll do an upper endoscopy. In many cases, we'll even remove a gallbladder. And if the patient continues to have pain, then we start to subject them to more sensitive tests, or what we consider more sensitive tests, which could include endoscopic ultrasound, secret-enhanced MRCP, and endoscopic pancreatic function testing. The idea is if any of those tests are abnormal, the patient must have pancreatic fibrosis, and therefore they have a diagnosis of non-calcific, early, or minimal change chronic pancreatitis, depending on what you want to call it, and that must explain their upper abdominal pain. I guess the question is, does that really make sense? Because I think this is really how we, at least in the United States, this is in large part how we have been diagnosing a large number of chronic pancreatitis patients, is using this paradigm. Now let's remember that pain does not correlate with even advanced imaging findings in chronic pancreatitis. This was a nice study published by the Pittsburgh group using the NAPS2 cohort, which you know is one of the largest prospective studies ever conducted anywhere in the world, looking at recurrent acute and chronic pancreatitis patients in comparison with a very large control population. And as you can see here, look at all the variables here. These are all advanced imaging findings. Yet if you look at the pain pattern, everything from no pain to type E pain, these are very subtle distinctions made between different categories of pain. There was really no significance across all the various advanced imaging findings. So I think it's important to understand really what are the neurobiologic principles of visceral and pancreatic pain. If the pancreas becomes chronically inflamed and starts to develop fibrosis, all the nociceptive impulses are carried back through the pancreatic primary afferent, through the celiac plexus, synapsing in the dorsal root ganglion, coming back into the spinal cord, and then up into and then back up into the cortical structures. One thing to remember is that as the rate of nociceptive impulse increases, what we think happens is that not only do the nerves of the pancreas begin to increase in volume and hypertrophy, all those nociceptive impulses actually cause central sensitization, right? Because they're constantly the entire central system is being bombarded with these nociceptive impulses. So that's in fact the basis of central sensitization. So we do know, and I think that this is also another very important, two really important points about pain. One is that really the neuropathic changes, but not intraductal pressure, probably best correlates with pancreatic pain and chronic pancreatitis. For many, many years, we've been operating on the intraductal hypertension hypothesis, right? So if you have a dilated duct with strictures and stones, you have increased pressure in the duct, and that's transmitted into the interstitial space, and that is the source of pain. The problem with this is that if you go back and you look at all the studies that have ever been conducted, looking at the outcomes of surgery and endoscopic therapy for treating pain according to the increased intraductal pressure, we're still only seeing improvement in pain at about a third, permanent improvement to maybe about another third, and 1/3 of patients have no pain improvement at all. So that can't be the only explanation for why patients actually have pain. What is probably a better theory is the one focused on neuropathic changes that are all provoked by inflammation affecting the pancreatic nerves, and as well as to neural hypertrophy and neural density. And the basic science studies are very strong in supporting this. I think that, so really it's about the wiring and not the plumbing. I think that's a real simple way to think about this. The second point is as you have an increased bombardment of those nociceptive impulses back into the cortical structures and the spinal cord, you begin to develop nociceptive or central sensitization. So this is really the key player of pathogenesis of pain in chronic pancreatitis. And we also know that there's been other studies that have shown us that central sensitization is very common in patients with chronic pancreatitis. I think this is a very nice schematic showing that, where when you test, when you look to see where cortical activity is greatest based on stimulating various parts of the esophagus, stomach, and duodenum, you can see the patients with chronic pancreatitis have very disordered central processing of pain. So the areas that were stimulated, the red was esophagus, the green is the stomach, and then the duodenum is in fact the blue area. When you actually electrically stimulate those patients, normal patients, you can see that all the pain is kind of lying in the area where we think the visceral organ sits. However, in patients with chronic pancreatitis, you can see it's very, very disordered. And we know that central sensitization affects pain outcomes. This was a study conducted in the Netherlands where 48 patients underwent surgery for chronic pancreatitis, 30 had a good pain response, and 18 had a poor pain response. And we know that quantitative sensory testing, which was a testing that can be performed to determine whether or not a patient has central sensitization, demonstrated significantly increased sensitization in patients with a poor response. So the question they are obviously brought up is that maybe we should be performing this preoperatively so we could use it as a patient selection tool before we actually subject patients to surgery, and for that matter, why not endoscopy? We also know that the timing of surgery and opioid use can affect pain outcomes. On the left, you can see a nice study conducted by a Dutch group looking at the outcomes of many patients who had undergone pancreatic resection and drainage procedures, and they had identified 3 factors that seemed to be associated with an increased likelihood of having a good pain response. And one was having pain for less than 3 years. The second was not being on any narcotics prior to surgery and having a limited number of endoscopic treatments. And all of these had fairly robust odds ratios in the multivariate analysis. This study was, in a way, replicated by a group at Harvard Medical School, which attempted to identify cutoffs for patients who actually did better with pancreatic surgery, and they actually they plotted this as an area under the receiver operating curve, which wasn't great. It was only 0.66, but they looked at a cutoff and they found a 26.5 months seemed to be a reasonable time point. So in other words, if you were operated on within 26.5 months, you were more likely to have a positive pain outcome than if you were operated on after that 26.5 month framework. So here they identified less than 3 years, and it looks like we're driving the cutoff a little further down. Does etiology of chronic pancreatitis affect the outcomes? And we do know that one study, this was conducted in the University of Alabama, reported lower islet yields, higher postoperative insulin needs, higher pain scores, and lower quality of life in patients with alcoholic versus non-alcoholic chronic pancreatitis. Some considerations of this study was about 1/3 of the patients who had actually been enrolled in this study had actually had a partial pancreatectomy prior to total pancreatectomy. We do know from a separate study conducted by a group in the Netherlands that disease severity affects central sensitization. So we also know that alcoholic patients tend to have more advanced disease at the time of diagnosis, right? Most of these patients have chronic calcifications, a very atrophic gland, very dilated ducts. So the disease severity likely increases central sensitization. We know that sometimes these patients have a hard time stopping their alcohol use, and that might affect their outcomes. And certainly, if you have increased disease severity and you've had it for longer, then you're already kind of going outside the window of timing where this is going to be effective. Now I'm going to talk a little bit about the outcomes, and I'll go through this relatively quickly because I think a lot of what I spoke about is somewhat showing us why we have the outcomes we have. This was the first systematic review conducted looking at 5 separate studies of patients who had undergone total pancreatectomy with islet autotransplantation. And really, several of the studies were poorly done because they didn't really record pre- and postoperative morphine use. But of the 2 that reported pre- and postoperative morphine use, you can see that there was a decreased use of narcotics in 2 studies, and that was statistically significant. The largest series that has been shown looking at outcomes for post-total pancreatectomy and islet autotransplantation patients comes from the University of Minnesota. They followed a total of 410 patients between 1977 and 2010, I think. And at follow-up, at a 2-year follow-up, about 51% were still on narcotics, so about 49% had come off of narcotics. I think one thing that's important to remember about the University of Minnesota cohort is that, in fact, a large number of patients had prior pancreatic surgery. So that, once again, that also shows that these might have been patients with advanced disease who had had surgery, so they had longer duration of disease, and then they undergo total pancreatectomy and islet autotransplantation. So that might have something to do with why some patients have not been able to come off of their narcotics. Now, we also know that etiology and prior surgery can certainly impact pain outcomes. We've been talking about that all along. This was a study from a separate group at the Medical University of South Carolina 17 out of 33 patients were followed for 1 year, and unfortunately 77% were still on narcotics. However, I think one of the big explanations for that is that this center actually operates on people with sphincter of Oddi dysfunction. So as my mentor used to say, sphincter of Oddi dysfunction, SOD, is otherwise known as some other disease. So if you're going to do total pancreatectomy for this, you better be careful, because I think it's going to limit your outcomes. And as you can see, almost 19 of these patients had had a prior surgery before undergoing total pancreatectomy. At my center, if we look at our preoperative and postoperative oral morphine equivalents, we've clearly had a significant decline in the amount of narcotics that our patients are on. We don't have the duration of follow-up like the University of Minnesota, because they've actually been doing this for much longer than we have. And at this stage, at about 1.5 years, we have about 41 patients who are completely off of narcotics, and about 59% who are still on it, but could be on it to a very limited extent. Let's talk a little bit about islet cell yield. We know that these are the factors that affect how many islet cells you get, and obviously this is a very important issue, because if you're going to operate to take away somebody's pain, you don't want to leave them with brittle diabetes, right? So these are some of the considerations. So patients who've had prior surgical resection, prior surgical drainage, obviously people who've had longer disease and increased pathologic fibrosis, these largely go together, and those who are obese are going to probably have less islets than other patients. And this has been shown before, where you can see the patients who've had no surgery have higher islet yields than those patients who've had pancreatic resection and or drainage. The patients who've had prior drainage procedures, Fry and Pousteau and Bager, they have the least, because you've opened up their ductal system. So you have nothing to inject the collagenase in to break down the islets in the islet separation process. If you look at the outcomes, I'm going back to the University of Minnesota data, because they have the longest experience so far. If you go out to about 3 years, you're looking at the rule of thirds. So 1/3 will be insulin independent, 1/3 will be on some insulin, and the other third will be completely insulin dependent. Now I'm going to talk a little bit about the complications, and then I'll finish up. I hope I'm not running too far over time. But we do know that one of the most common complications, apart from the ones that we commonly know of, obviously anybody who undergoes pancreatic surgery can experience those surgical complications that are related to the surgical procedure. But I think one of the unique medical complications is really what we would call either gastrointestinal dysmotility or delayed gastric emptying. Recently, my group published this paper where we found that about 1/3 of patients have some degree of delayed gastric emptying in the postoperative period. And the problem with that is that in many patients it can persist. So if you start to follow these patients, this is known as the gastroparesis cardinal symptom index. So if you're above 3, you're considered severe. And now when you actually plot out and look at the impact of this dysmotility on quality of life, you can see there are statistically significant associations between the SF-12 mental health and physical health survey. And we also know that this dysmotility is independent of the effect of narcotic. A lot of people will come up to me, they're like, but that's because your patients are still on narcotic. In fact, a lot of our patients are off of narcotics, but they still in fact have the gastrointestinal dysmotility. And we also know that long-term GI symptoms are not related to pancreatic enzyme replacement, because some people say that maybe we're underdosing or overdosing. But the truth is this study, also coming from the University of Minnesota, shows that patients still have some degree of constipation that's statistically significant compared to baseline, even at 3 years. And these are patients who are taking adequate doses of pancreatic enzyme supplementation. We also know that laparoscopic versus open approach doesn't seem to affect the rates of delayed gastric emptying or GI dysmotility. Obviously, we have not been doing, most of our cases beyond 2 years were done open, and since that time we've in fact been adding to our laparoscopic series, but we don't see any statistically significant differences at these various time points. So in summary and conclusions, I think current selection criteria are not optimal because of the difficulties of diagnosing chronic pancreatitis and our limited understanding of pancreatic pain. We need to focus more on the history of the patient. That is, do they have a history of acute recurrent pancreatitis, rather than diagnostic testing, including EUS, MRCP, and endoscopic pancreatic function testing for diagnosing chronic pancreatitis. And we need to consider etiology, timing of surgery in relation to duration of symptoms, and preoperative opioid use in selecting patients. I think we need to develop tools to diagnose and treat central sensitization. I think if we can do that successfully, maybe we won't even have to do total pancreatectomy anymore, because if you think about it, as pancreatologists, we don't want anyone to lose their pancreas. We want them to keep it, right? So at the end of the day, if we can treat their pain better, then we might not actually need to do this radical procedure. As you can see, the pain and glycemic outcomes are heavily influenced by patient selection. And gastrointestinal dysmotility is common after TPIAT. It's extremely under-recognized and impacts pain outcomes. I think further research in this area will not only help our TPIAT patients, but certainly all patients undergoing partial pancreatic surgery. Thank you very much for your time.
Enrique?
Thanks, Vikesh, for your awesome presentation. We are really honored to have you here. You come from the best-rated hospital in the States. You are developing the pancreatic clinical field there. You are making a huge amount of investigation on acute and chronic pancreatitis. You are leading collaborative studies, randomized controlled trials. You are making a good job. Here in Spain, we don't have this technique. It's not available. And it's a very invasive procedure, and what I would find most difficult is to decide if the patient that is sitting in front of me should go for that. For example, I have a couple of patients with minimum change chronic pancreatitis with pain that are under strong opiate treatment, but you have you have some doubts about if this is the cause of the pain, because to go to a procedure like that, you may die, for example. It has a mortality or great secondary effects. Is it difficult to have, personally, to have these considerations? And it should be hard to send a patient to this kind of procedure sometimes, no?
Yeah. That's an excellent question, and of course this is the biggest issue that we're wrestling with across the United States right now, because we have at least maybe 10 or 11 centers that are now performing this in the US on a regular basis. I think that what I've come to realize is it's better to restrict rather than be more open. I think the Minnesota program is a little bit more open in whom they actually perform the procedure in, and I think other centers are starting to think a little bit more carefully about who to do this in. I will tell you, I think that the patients who do the best, just from my personal experience, although the data I think is going to be a little bit more limited, are people who have gene mutations. Of course, anybody with acute recurrent pancreatitis, patients with pancreas divisium who have acute recurrent pancreatitis, I think patients who are younger, patients who are not on that much narcotic, those who have not been operated on before, and once again have a somewhat limited duration of disease. We have really stopped doing the toxic chronic pancreatitis patients, so we're not doing the patients who are alcoholics and who are also smoke or may smoke heavily, because I think that the outcomes in them are just not as good. I think if you direct this to that more sort of very restricted patient population, I think you can actually achieve pretty good outcomes. But I think time will tell, and certainly once we get to a point where we can actually publish our results, I think we'll have better results to show. But thank you for the question. Yeah.
Luis?
Good morning. I congratulate you on an excellent presentation. My question is simple. Are you aware, is there any ongoing or completed trial, randomized trial comparing this technique with a simple pancreatic head resection in terms of final results, long-term results?
Excellent question. No. That's a simple answer. But I think that would be a very interesting study to pursue. I think if we sort of see where this might be going, if we start to limit this more to patients with gene mutations, remember 1 to 2% of the entire population has a SPINK1 gene mutation. In the United States, 1 out of every 25 people in the whole country has a CFTR gene mutation. Now that doesn't mean they have cystic fibrosis or they're ever going to have acute recurrent pancreatitis, but at the same time, we have mutations out there that I think are causing this in more people than we think at present. But I think in those patients, if you do a partial pancreatectomy or a drainage procedure, you're still looking at a gene mutation that's causing a field defect throughout the whole pancreas. So in some ways, it might make more sense to take out their pancreas, because I think in them, if you do a partial resection or drainage procedure, they might continue to have acute pancreatitis. They may continue to have pain. So this could be one way to solve their problem once and for all. But once again, it might mean that rather than doing it in everybody, we only limit it to this smaller group of patients.
Dr. Sabater?
Congratulations about your work and your presentation. Thank you very much.
Thank you.
I wanted to ask, first I wanted to do a comment. Total pancreatectomy is really a bad operation for chronic pancreatitis in terms of curing the pain and so on. It's the last operation you have to do at any time. Okay. So, but then the problem is if you don't do a total pancreatectomy, you don't get the number of islets enough to prevent the diabetes. And then I wanted to ask, what is the mean number of islets necessary to avoid diabetes, and whether they, what is the, how long do they, what is the duration, the mean duration of the islets? Because in the program of the Minnesota and Minneapolis, the experience they had is that the islets worked very well during the 2 first years, but then they started to stop the function. And then the patients recur with the diabetes mellitus. So what's your experience about that? Do the islets dure a long more? Do you give any medication to make them any longer, or they stop the function?
Right. To the answer to your first question about total pancreatectomy, obviously I think it's a little bit under debate. I think really what I've tried to highlight here is I think we have to be more restrictive. I think if we're restrictive, we'll have better outcomes, particularly in the gene mutation patients. There is no number of islets that, obviously islet is, the number of islets you get is correlated with your ultimate glycemic outcomes, but there are a lot of other factors that are important. And probably the one that I think is the most important is also the quality, right? So we keep talking about quantity, but quality is just as important. So you might get a lower number of islets in a younger patient, but their quality might be better than somebody who's 70 or 80. So they might do better in the long term. We don't do this in anybody, first of all, who is already a diabetic. So if you're even on oral hypoglycemics or you're on insulin, we don't do it. We do it in some patients who are pre-diabetic in order to maximize the yield and also to ensure that we have better quality. I do know at some other centers they're starting to use immunosuppressive agents in an effort to actually sort of prolong islet life. That's being done by Marlon Levy's group at Baylor University. That's not part of widespread practice, but that's something that his center believes in. So I think you have to think a little bit about it in terms of quantity and quality. Now remember, once you infuse the islets, they stop dividing. So what you get on day one is what you're going to have for your whole life, because after that the population begins to decline. The data I'm showing you so far is the best data we have really at 3 years. That's showing up based on a large number of patients as to what the glycemic outcomes are. And I showed the 1/3, 1/3, 1/3, right? 1/3 on insulin, 1/3 on some insulin, and 1/3 on no insulin. I think we're going to have to do things to try to see if we can somehow improve that bar. But now also remember that the natural history of chronic calcific pancreatitis is diabetes. So depending on when you actually operate on somebody, that's also going to impact your yield, right? So if you're doing more patients with bona fide true chronic pancreatitis, you're going to get less and less islets. And that's what we've found actually with time. If you start to do sphincter of Oddi dysfunction patients and start doing patients who have chronic pain due to other causes, you're going to get a lot more islets. They're going to have better glycemic outcomes, right? So I think these are some of the considerations that you need to think about when you're actually thinking about the islet autotransplantation. Are there any other questions? Don't be shy.
Vikesh, any other questions?
You can catch me, of course, afterwards.
Vikesh, I have a question. I have a lot of questions, but only one. Is there any kind of complication related to the islet autotransplantation?
Right. So probably the leading complication to the islet autotransplantation is portal vein thrombosis. Now, it used to occur more frequently, I think in the 70s and 80s when this had first started, but recognizing that you need to minimize the amount of tissue volume and the rate of infusion has substantially reduced that risk. One other thing we also do in almost everybody before we do the operation, because if the patients had recurrent acute pancreatitis, they might even have some portal vein thrombosis. So you want to make sure there isn't already a clot there or some clot burden, because that could actually affect the risk of that happening again. But that's probably the main risk, and that's the most consequential risk too.
And it's possible to do the transplant in another site?
Yes.
If you can do in the liver, you can do in another site?
That's an excellent question. In fact, people have explored a number of sites, including the kidney capsule. They looked at the omentum. You can, in fact, put them anywhere. We found the liver to be the most accessible and the easiest, but you can put them anywhere. As a matter of practice, we've been largely sticking with the liver, and I don't know if there's any strong data to suggest that that's either better or worse than any other site in the intraperitoneal cavity.
Thank you a lot.
Okay. All right. Thank you, everyone.
You can go to take coffee.